So it's the classic case of orbital compartment syndrome. Vision loss, proptosis, and a high IOP. That's the triad. It's not a reliable triad though, because the majority of patients will probably not have vision loss. Well, hopefully they don't by the time you evaluate them. Proptosis, again, hard to assess, especially in a really swollen, bruised eye in the setting of trauma. And so one of the most reliable signs here is this high intraocular pressure, the IOP. And when you do see that, that's going to need immediate decompression. Time is retina here. And we say this a lot in terms of other organ systems. Time is brain, time is heart, time is leg for compartment syndrome. Well, for orbital compartment syndrome, time is retina. And the imaging and the specialists are going to have to wait. The imaging being CT scan. We talk so much about entrapment, looking for extraocular eye movement issues. Sure, all that's very important. But probably the most important thing you can evaluate for is actually orbital compartment syndrome, because that's the most actionable item in the emergency department. Consulting your specialist is very important here, but a lot of emergency departments don't have access to those specialists. And that means you are going to be the one doing this. And so the key findings here, again, we're talking about acute vision loss as a late finding, fixed pupil, late finding, very late finding for optic nerve ischemia. The high IOP we mentioned a minute ago, that's going to be greater than 30 typically. That's a low cutoff. The textbook says greater than 40, but really you should be having alarm bells going off in your head for anything greater than 30.